A case of difficult asthma. So what is this case? Right now I have a 7-year-old girl child with a recurrent wheeze. Wheeze was documented by pediatrician multiple times, but the wheeze was not responding to inhaled corticosteroids. One of the prescription was documenting a little bit of corticosteroid along with wheeze. There are no constitutional symptoms like fever or weight loss. Anthropometry was otherwise absolutely fine. So right now, I have a case of 7-year-old child with documented wheeze, which has been there for 2 to 3 years on proper inhaled corticosteroids. No one tried pulmonary function test. One documented strider that pediatrician had mentioned wheezing also. No constitutional symptoms. So let me not think about TB, etc. Okay. And it was not no mention regarding crepitations, so that I need not think in terms of primary ciliary dyskinesia, cystic fibrosis, primary immunodeficiency, etc. So a normal child with a normal anthropometry without constitutional symptoms, with on and off documented wheeze, not responding to bronchodilator, a little bit of corticosteroid. So what is this case? Right. So whenever I have a case of wheeze not responding to SABA, short acting beta 2 agonist, I need to have differential diagnosis in my mind. Is it a case of vocal cord dysfunction? Vocal cord dysfunction is a condition which often occurs in adolescent age group. So in which you will have adduction of vocal cords, unusual adduction of vocal cords. Normally during inspiration you need to have abduction of vocal cords, but the cords at times unusually adduct, leading on to stridor and suprasternal retractions. But it usually occurs in a older age group, but in a 7-year-old child it can occur but unlikely. Right. Is it a case of gastroesophageal reflex? How could a gastroesophageal reflex can produce stridor? These can be yes, occasionally gastroesophageal reflex because of reflex mechanism. It can be a cause or a association with recurrent wheezer. But I don't know whether that gastroesophageal reflex leading on to laryngospasm. I don't know. Or is it a case of neutrophilic asthma? So what is this neutrophilic asthma fancy term? It doesn't mean that all asthma or all wheezes will respond to your inhaled corticosteroids. Sometimes instead of eosinophil causing damage to the underlying airway, instead of eosinophilic bronchitis, you can have neutrophilic infiltration. This will not respond to inhaled corticosteroids. So do I need to do a bronchoscopy and look for neutrophils in the lung? I really don't know. So we were planning for that. Or it is a case of spasmodic group. So many times in a known wheezer, you can get recurrent allergic croupy cough. That subglottic area will be unusually sensitive to allergens. So almost in less than 5% of children with a recurrent wheezing, they can manifest with a recurrent allergic spasmodic croup. Is it so? How can I document that? I really don't know. Or it could be an extraluminal compression like a vascular ring, causing compression of your trachea as well as your bronchus. Is it an innominate artery or a double aortic arch or a comoral diverticulum? I really don't know. For a pediatrician, is it a vascular ring? So what should I do next? So what are all the investigations I need to think in terms of? Should I go for a flexible bronchoscopy to look for an vocal cord abduction, adduction? Should I look for any unusual collapsibility of the trachea and bronchus or a pulsatile trachea and bronchus to identify underlying tracheobronchomalacia, or should I do a barium swallow study to look for GR producing reflex vocal cord spasm, or should I go for contrast enhanced CT again to look for an extraluminal compression of trachea and bronchus? So what investigations do you think will be useful right now? So let me give 10 seconds for you to think. So choose one diagnosis, choose one investigation so that it will be helpful to identify the underlying etiology. 10 seconds. Yes. What investigations you want to do? Yes. We were also thinking in terms of so many investigations. But remember, my dear friends, history and physical examination always matters. Whether you are a pediatric pulmonologist, gastroenterologist, nephrologist, neurologist, physical examination matters. So, what is one physical finding which helped us to find out the underlying etiology? Yes, look at this. What is this? This is called Garland sign. The child is able to touch her nose with her tongue, and it is not possible for you and me to. Look at this. There is an abnormal kyphoscoliosis. Yes. Look at this. There is abnormal hyperextensible elbow. Hyperextensible elbow. And finally, unusual elasticity of the skin. Unusual elasticity of the skin. So what is the diagnosis? What is the diagnosis? You all know that this is a case of Ehlers-Danlos syndrome manifesting as difficult to treat asthma, not responding to inhaled corticosteroids. You must be asking me, how does an Ehlers-Danlos syndrome can produce stridor and wheeze? The answer is very simple. Ehlers-Danlos syndrome is a condition in which you will get abnormal weak collagen. That's why you will get aneurysm, ruptures, etc. So because of that unusual weak collagen, you will have tracheomalacia, you will have bronchomalacia. So a weak trachea leading to increased collapsibility, leading to on and off stridor. A weak bronchus leading on to increased collapsibility and leading on to recurrent wheeze. So always you need to think in terms of a physical examination in case of recurrent wheeze. So this is a case of Ehlers-Danlos syndrome manifesting as recurrent wheeze and stridor. So think in terms of these underlying rare conditions when your standard treatment asthma protocol with inhaled corticosteroids doesn't work. There are many case reports in which Ehlers-Danlos syndrome were presented as recurrent wheezer or stridor. Thanks a lot for your patient listening. Bye bye.